People who exercise intensively for about 4 hours at least every week do develop a plethora of structural and functional changes that are basically adaptive to generate a large and sustained increase in cardiac output. In general, athletes get a 10 to 20% increase in left ventricular wall thickness, a 10% increase in left ventricular and right ventricular cavity size, which amounts to a 45% increase in left ventricular mass when we compare them with age, size, and sex-matched individuals who don't exercise very much. So this is what you normally see. However, the magnitude with which these manifestations occur is governed by several demographic factors and the type of sport. Demographic factors include age, sex, size, and ethnicity. Then there's the type of sporting discipline, the use of concomitant performance-enhancing agents, and of course, there may be some athletes who develop big dimensions not because of athletic training, but because they may actually have a hereditary cardiomyopathy. Here is basically a bar chart of Italian Olympian athletes, where you've got the females in the red bars and the males in the blue bars. The first thing to note is that males have bigger dimensions than females, and that's not surprising. They're larger, greater lean body mass, able to exercise much more intensively. But the most important point I want to make is that 48% of these athletes have a left ventricular cavity size that exceeds the upper limit of normal for the general population, and 14% of these athletes have a left ventricular cavity size of 60 millimeters, which could be consistent with dilated cardiomyopathy. The same applies if you look at the right ventricle. So it's very common for us to see athletes with big left and right ventricles. The situation is not so common when it comes to wall thickness. Here is an athlete. The wall thickness in athletes very rarely exceeds the upper limit of normal. By that I mean it's unusual to see a left ventricular wall thickness of more than 12 millimeters in white athletes. So in sports cardiology, we are frozen. We are often faced with an athlete who's got a wall thickness of more than 12 millimeters, or we're faced with an athlete who's got a big left or right ventricle, not just alone, but a big left or right ventricle that's associated with what looks like borderline low ejection fraction, raising the possibility of dilated cardiomyopathy and ARVC, or hypertrophic cardiomyopathy when you look at hypertrophy. And this is more so when there are concomitant repolarization changes. And the type of athlete that this affects is usually your endurance athlete, your long-distance cyclist, runner, rower, canoeist, or your athlete of African or Afro-Caribbean origin. In these particular situations, it's absolutely crucial for a sports cardiologist to get the diagnosis right, because an erroneous diagnosis has very serious consequences. For example, an erroneous diagnosis of cardiomyopathy in an individual who's got physiological increases in cardiac size may lead to unnecessary disqualification from sport that would cost that individual physically, psychologically, and potentially financially. Conversely, of course, an erroneous diagnosis of the athlete's heart in someone with cardiomyopathy could potentially jeopardize a young person's life, and that could come back and haunt you at a later date. So we've got to get this right. I want to do this in a very simple way, that we're going to do this with history, demographics, ECG, and the echo, because these investigations are available to all of us. And some people need more tests in the form of exercise testing, cardiac imaging, evaluation of first-degree relatives, and even genetic testing. In terms of history, clearly, if someone's got chest tightness, breathlessness, that's disproportionate to the amount of exercise being performed, dizziness, palpitation, syncope, that's clearly an ominous feature and favors pathology. The family history is very important because most cardiomyopathies are inherited as an autosomal dominant trait. So if your athlete has a family history of premature cardiovascular disease or sudden cardiac death in a first-degree relative below the age of 40 years old, you take those structural changes much more seriously. So physiological left ventricular hypertrophy versus hypertrophic cardiomyopathy. Here's a bar chart showing you the wall thickness distribution in over 3,000 white athletes. And what I want you to appreciate is the vast majority of your athletes have a wall thickness of between 7 and 12 millimeters, but a very important minority, specifically 1.5%, have a wall thickness that ranges from 13 to 16 millimeters, which overlaps with morphologically mild hypertrophic cardiomyopathy, and this particular condition is regarded as the commonest cause of sudden cardiac death in young athletes in the Western world. And this sort of thing usually affects adult Caucasians who are male with a large body surface area participating in endurance sport. This is the type of animal that develops a wall thickness of 12 millimeters or more. We don't see it in white females at all, and we very rarely see it in adolescent white males aged under 16 years old. The black athlete story is quite different. It's relatively common in black athletes, one. It may occur in black females and may also occur in black adolescents. The magnitude of left ventricular hypertrophy. Here's a bar chart comparing white athletes in the gray bars and black athletes in the black bars. And you will see that whereas only 1.6% of white athletes have a wall thickness exceeding 12 millimeters, the story is quite different with black athletes in that 13% of black athletes have a wall thickness going above 12 millimeters. So 2 points on this slide. Firstly, black athletes get more hypertrophy than white athletes. The second and very important point is that no matter whether you're white, black, Chinese, Indian, whatever your race, you never see a wall thickness measurement of more than 16 millimeters in a male. And if you do, you should consider pathological hypertrophy. The pattern of hypertrophy is quite important. Many of you are aware that hypertrophic cardiomyopathy is very morphologically diverse, and all sorts of bizarre patterns of hypertrophy are recognized. Many people with hypertrophic cardiomyopathy either get asymmetric septal hypertrophy or hypertrophy confined to the apex, as you see here. Asymmetric septal hypertrophy, hypertrophy confined to the apex. Now, we don't see this type of bizarre hypertrophy in athletes. In athletes, you see concentric left ventricular hypertrophy. Now, many of you will say, but you also see concentric left ventricular hypertrophy in hypertrophic cardiomyopathy. You do. But going back to our athletes with hypertrophic cardiomyopathy, this pattern is only present in 15% of athletes who actually have hypertrophic cardiomyopathy. Most athletes with hypertrophic cardiomyopathy have either asymmetric septal hypertrophy or apical hypertrophic cardiomyopathy. In athletes, the pattern of hypertrophy is very homogeneous, and there is no more than a 2 millimeter difference between adjacent segments. As you can see here, the septum measures 14 millimeters, the posterior wall 13 millimeters. If you look at the anterior wall, the posterior wall, the inferior wall, the lateral wall, there's no more than a 2 millimeter difference between adjacent myocardial segments. So it's a very smooth pattern of hypertrophy. Athletes with hypertrophy also invariably get big left ventricular cavity dimensions. In hypertrophic cardiomyopathy, hypertrophy occurs at the expense of the LV cavity size, whereas in physiological hypertrophy, left ventricular wall thickness is an adaptive phenomenon in response to a large LV cavity in order to maintain wall tension. And what we normally look, if we look at the left ventricular cavity size in relation to wall thickness, and we measure the HR ratio. Here you've got two athletes, one who's got hypertrophic cardiomyopathy, and the other that's got physiological left ventricular hypertrophy, both with a wall thickness of 13 millimeters. But the person with hypertrophic cardiomyopathy, if you look at their HR ratio, that's the wall thickness to cavity ratio, H equals the septal thickness and the posterior wall thickness, R equals the LVID, the left ventricular end diastolic dimension. If you measure this, it's 0.54. Our cutoff at St. George's is if you've got a HR ratio of more than 0.54 in males, we consider that as pathological hypertrophy. If you've got a ratio of more than 0.48 in females, we consider that as pathological left ventricular hypertrophy. This is a good formula to use in people who've got concentric hypertrophy. An athlete, here's an athlete, and if we measure this athlete's HR ratio, it's 0.47, so within normal limits. What about indices of diastolic function? We know that athletes have normal or supranormal indices of diastolic function, as evidenced by E2A ratios that exceed 2, or E primes that exceed 9. That's what the cutoff says, 9, but athletes normally get E primes of 20 or 25 centimeters per second. In contrast, of course, people with hypertrophic cardiomyopathy often have abnormal diastolic function. And this table compares all these various parameters of diastolic function between physiological left ventricular hypertrophy and hypertrophic cardiomyopathy. And for the sake of time, I'm not going to go through any of these, but I want to reassure you that my talk will be available on the CRY website a couple of weeks after, maybe a little bit longer, and you can pick some of this up. This is all very good when you're looking at big cohorts. So if we took 600 hypertrophic cardiomyopathy patients and we took 600 athletes, this works extremely well. But on an individual basis, this is absolutely useless. So the absence of diastolic dysfunction should never reassure you in an athlete. So if you've got an athlete who's got completely normal diastolic function, that doesn't mean they don't have hypertrophic cardiomyopathy. And here, this is some work looking at the sensitivity and specificity of various parameters of diastolic dysfunction. Clearly, if they're not there, that's a very good sign. It means there's probably nothing wrong with that individual. Sorry, what I mean is if they're absent, then that's, if they're present, then there's obviously something wrong. But if they're absent, then you can see the sensitivity here ranges from only 5 to 35%. So the absence of diastolic dysfunction should not reassure you. Its presence does make you think of a problem. Indices of systolic function. We always believe that hypertrophic cardiomyopathy is characterized by hyperdynamic systolic function. You've got a small LV cavity, thick walls, very small cavities. Of course, if you calculate the ejection fraction and the fractional shortening, it'll be high. So I wouldn't look at your ejection fraction and fractional shortening. I would look at longitudinal function. And longitudinal function, which is usually measured by systolic annular velocities of the mitral valve, are more sensitive. A value of more than 10 is suggestive of physiological LVH. A value of less than 10 makes you think of hypertrophic cardiomyopathy. Tissue Doppler longitudinal strain is also important. You can imagine if in longitudinal function, the heart contracts like this, so longitudinal strains go downwards, they become very negative. In hypertrophic cardiomyopathy, you've got regional wall motion abnormalities giving you paradoxical strains, and the longitudinal strain is usually more than minus 11%. So we get loops a little bit like this, a short S wave and paradoxical loops on longitudinal strain. Clearly, sometimes you can say to yourself, well, if I detrain this individual, and if the hypertrophy goes away, that's great, and that's all very good. And that may give me the answer. Regression of hypertrophy after detraining is equivalent to physiology. Persistence is equivalent to pathology, but it's very hard to convince a top athlete to detrain. Detraining for even 4 weeks costs fitness and team selection. For a young individual aspiring to get into the A team, they will not be willing to detrain for you. This is sometimes possible in football and some sports where there's an off-season, but even football players, they don't detrain for too long. Even when they're sunning themselves on the beach, they still go to the gym every day. I was talking to Harry Kane, and he said he went to the gym every day religiously despite being on holiday, so they still train very hard. Again, I can't go through this. I've talked to you about this. This is the Venn diagram differentiating hypertrophic cardiomyopathy from athlete's heart, and there are various parameters that you can use, and you'll pick this up on the website when this talk becomes available. But the ECG has an important role. Sometimes the echo comes back normal, and you're still thinking, well, it's not quite normal. The wall thickness is 14. I'm still not sure. There's a lot at stake. Will the ECG help me? Here's an ECG of an athlete showing sinus bradycardia, voltage criterion for left ventricular hypertrophy, incomplete right bundle branch block. I want you to focus on the large voltage criterion for left ventricular hypertrophy, where the S in V1 plus the R in V5 and V6 equals more than 3.5 millivolts. The important thing here is that this athlete does not have any other features to suggest pathological left ventricular hypertrophy, i.e. there is no evidence of ST segment depression or T-wave inversion in the lateral leads. You don't see that in the athlete's heart. So isolated voltage criterion for left ventricular hypertrophy, physiology, T-wave inversion in the infralateral leads, or ST segment depression makes you think of pathology. Clearly, we've got to look at the black athlete's ECG, which is a little bit different because black athletes do get T-wave inversion. Here is a normal black athlete's ECG demonstrating J-point elevation in leads V1 to V4 with convex ST segment elevation in those leads and deep asymmetric T-wave inversion. You are allowed, this ECG pattern in black athletes is present in about 13% of black males. So T-wave inversion in V1 to V4 is normal, but if you see T-wave inversion in the infralateral leads, even in black people, that is not normal. This is not normal. So this pattern, infralateral T-wave inversion, is considered pathological and requires comprehensive investigation, and if following MRI and all the other tests you cannot explain the diagnosis, you can't come up to a diagnosis, then that individual can compete. But the important thing is that you don't forget about them. You bring them back every year, because what's not there in 2015 may be rife in 2018. And this study shows this. This is a study of 155 athletes with deep T-wave inversion. 84% had T-wave inversion in the inferior and lateral leads. And do you know, when they did echo and MRI on these individuals, 46% of this group were diagnosed with a cardiomyopathy. 46%. So it's an important ECG pattern. You don't need to be Einstein to be absolutely certain that this is very, very abnormal. Deep T-wave inversion in the mid-precordial leads in V4 to V6 with ST segment depression should always make you think of a specific form of hypertrophic cardiomyopathy. Does anyone know which one? Apical hypertrophic cardiomyopathy. So when you see this, the echo may be normal. This patient definitely warrants an MRI to show you apical hypertrophic cardiomyopathy. MRI does have advantages of the echo. It's better at picking up apical hypertrophic cardiomyopathy, better at looking at hypertrophy confined to the free wall, and better, or in fact, it's superior, far superior to echo, because echo can't show fibrosis where the MRI can. Exercise testing is good for those of you that are sports scientists. You will be aware that we normally exercise people who've got a stiff ventricle that's not compliant, where they've got diastolic dysfunction, myocardial ischemia, dynamic outflow obstruction. They will not be able to augment stroke volume like a normal athlete. So most people with hypertrophic cardiomyopathy have low peak VO2s, which are less than 50 mils per kilogram per minute, or less than 120% predicted, whereas athletes have a much higher value, and we often use this cutoff to differentiate between the two entities. But I'd like to finish with like-to-like comparisons. Up to now, everything I've told you is I'm comparing our top athletes, the British national rowing squad and our Tour de France athletes, with wall thickness of 12 to 15 millimeters, with our sedentary hypertrophic cardiomyopathy patients that are doped up with beta blockers and don't exercise very much because we tell them not to. That's not really a like-to-like comparison. So we are very fortunate here at St. George's because we probably get referred practically any athlete who has anything that looks like remotely backed. And over about 15 years, we have collected 106 individuals who were diagnosed with hypertrophic cardiomyopathy at the prime of their careers. These were diagnosed at the time. And this is what we found. We used the original echo and ECG. We found that athletes, compared to sedentary hypertrophic cardiomyopathy patients, have less hypertrophy. In fact, 45% of athletes with hypertrophic cardiomyopathy have a wall thickness of less than 16 millimeters, okay? Compared to sedentary individuals, they have a bigger LV cavity. And compared to sedentary individuals, they have normal diastolic dysfunction. They have normal diastolic function. Importantly, in athletes who are able to compete, in people with hypertrophic cardiomyopathy who are able to compete, hypertrophy is normally confined to the apex, which means the rest of the ventricle is free to contract normally. And it's those guys that have got just localized hypertrophy that seem to do very well. And reassuringly for all of you, the actual gray zone, that is concentric LVH with a wall thickness of only 13 to 15, only applies to 15% of athletes. Most athletes have bizarre patterns of hypertrophy or a wall thickness of more than 16 millimeters. So if you use the gray zone I showed you, you will pick up the vast majority. We then compared this very small group of athletes with concentric LVH and a wall thickness of 13 to 15 millimeters with athletes with physiological LVH, i.e., so we've got hypertrophic cardiomyopathy athletes with mild hypertrophy and our true top-notch athletes. We did find that hypertrophic cardiomyopathy athletes did have smaller cavities than physiological LVH. They had slightly inferior indices of diastolic function as well. But 13% of athletes had a big LV cavity. Your textbooks tell you that hypertrophic cardiomyopathy is characterized by a small LV cavity. But clearly, people who've been exercising all their lives with this condition, some people do have a big LV cavity. 93% of athletes had a lateral E prime of more than 9, which would have failed you if you'd have just read the textbooks. 100% had an E to E prime ratio of less than 12. Okay? But for the ECG fan, 98% of athletes had an abnormal ECG. In sport, your ECG tells you more than your imaging test do. What a paradox, eh? The cheapest test gives you some of the most important information. And that's good news for dunces like me and for the clever sports physicians and sports scientists as well. So I'm going to stop there because I'm absolutely want to keep to time. There is more in my talk, which you can pick up when you see when you pick up the talk on ARVC as well, in dilated cardiomyopathy. But this is usually the big one. So I'd like to finish by saying that in rare situations, we do get an overlap between hypertrophic cardiomyopathy and physiological LVH. If we use a systematic approach with history, demographics, ECG and echo, you can diagnose 85% just on that. The other small number require more expert input and more extensive investigation. Thank you very much for your attention.